recorded this lecture. So everyone can hear me now?
Yes, Professor.
Okay, and you can see my screen, which is the PowerPoint slides for online modules. What screen do you have at your end?
I'm seeing the one for anemia and blood transfusion.
Okay, so anemia blood transfusion, good. So we are going to cover 3 modules in which this content will be included in the exam for next week on Monday. So the session, I think that, questions and answering the questions and rationales, and we can discuss more concepts and go over the difficult, stuff here and maybe difficult concepts. That's a way of discussing content. Not necessarily has to be like PowerPoint slides with just content. We can do it through, while doing the questions. So before we start, as mentioned earlier, is that the three modules, which includes the anemia and blood transfusion, Alzheimer's, dementia, and the pain management, in which that I give you some, approximate, maybe like, percentage of questions that will be included as a preliminary, blueprint or some type of blueprint for exam 4. So you can manage your time, study time to, to go, you can, to be consistent with, with that. So at least because of the limited number of days to study for the exam. So when we talk about anemia and blood transfusion, I would say the most important types of anemia, other than that, also we mentioned earlier about the sickle cell anemia, other than the P&Ps, because that's a PEDS content already done in the other course. So other than sickle cell anemia, we have iron deficiency anemia, folic acid also deficiency, and vitamin B12 deficiency. The vitamin B12 deficiency is called megaloblastic anemia. Megaloblastic anemia, that's one type of that is going to be the vitamin B12 deficiency. And B12, and when we say vitamin B12, it's the cyanocobalamin. That's the, medical term or the actual, name for that vitamin B12, cyanocobalamin. And the cyanocobalamin or B12 is available as capsules or gel caps, as tablets, as injections, IM injections. So there are different formulas. When do you think we should we have to prescribe B12 if for a patient with B12 deficiency? The B12 formula or formulation or the type of drug supposed to be an IM injection for who? Who would be at risk for B12 deficiency, and we shouldn't be giving that patient tablets or gel caps or any type of other forms other than the only form should be a IM injections. And remember that there is also a game posted on Canvas, Jeopardy game. It's about blood transfusion and anemia. And you can play with that, Jeopardy game and find out about the answers as you flip through these slides. So who should be at risk for B12 deficiency? And we should, for that patient, should receive it as a IM injection and not PO and tablets or gel caps. Any idea?
Can be patient who had a gastrectomy.
Perfect. Why? Why do you think this patient should be at risk for B12 deficiency? And at the same time, it's contraindicated. We should not be prescribing any PO B12 for that patient.
Because they're not able to absorb it.
Because remember that the gastrectomy is, first of all, we have to go back to the pathophysiology, because B12 is usually absorbed through the intrinsic factor, the IF. And the intrinsic factor is this stuff that's going to be secreted and produced from the stomach, the top part of the stomach. So when we do post gastrectomy, patient has no tissues to absorb this B12, or at least to produce, or tissues to produce the intrinsic factor. So that's why we have to, first of all, definitely will have B12 deficiency, number one. Second, they need it, but not tablet. So it has to go right into the muscle and then blood stream to override the the absence of intrinsic factor. So, and this is actually one of the, if you go back to the GI problems, you'll find out that, some patients, one of the complications, serious complications post gastrectomy, either Billroth 1 or Billroth 2, post gastrectomy, other than the dumping syndrome or postprandial hypoglycemia. Also, number 3, the most serious complication post gastrectomy is vitamin deficiencies, especially B12. So let's go to the question. And I would like everyone to share, everyone to have a chance to read at least one question, please. Okay, I'll go with, the sequence of names I have right now. Michib, number 1, please. Michib, can you hear me?
Yes. Which type of anemia would the nurse suspect the client has developed?
So after reading the scenario, so the nurse is admitting a Black female client diagnosed to rule out anemia and history of gastric bypass surgery for obesity 4 years ago. And we will look at the MR or MAR, or some of the clinical manifestations, or here we have vital signs actually. So the client is now presenting with pale mucous membranes, dyspnea on exertion. So these are vital signs for this patient. Which one?
Could it be iron deficiency?
Iron deficiency.
B12. 12.
Remember, we already went over this, right? And we said B12. So we have specific cells in the stomach. Their function is to produce the intrinsic factor. B12 without this intrinsic factor will not be absorbed. So if we didn't have intrinsic factor because we have removed part of the stomach surgically, gastrectomy, then we have to provide it and override that step and give it IM injection. So because intrinsic factor allows the body to use vitamin B12 for absorption, so gastric bypass surgery reduces the amount of that tissue which produce this intrinsic factor drastically. So the client developed pernicious anemia, which is another name. So make sure that when you see pernicious anemia, sometimes it just said pernicious anemia, which indicates that it's a B12 deficiency status post gastrectomy. Remember that. So I don't, expect anyone in the exam to, ask what is pernicious anemia. So pernicious anemia is a vitamin B12 deficiency status post gastrectomy. Sometimes we just say pernicious anemia, but we know it's B12 deficiency post gastrectomy. So other clinical manifestations of anemia would include.
Professor, I have a question.
Yes.
So the patient only going to develop B12 deficiency only after gastrectomy, not like in general? Only after gastrectomy they develop B12 deficiency?
No, B12 so B12, we have other risk factors for B12 deficiencies as well as folic acid. So B12 deficiency, this is not the only risk factor. This is the most common one. Other factors, can be like, nutritional, like dietary restrictions. It can be, due to the, dieting or somebody who's on a crash diet right? So dietary risk factors is different from gastrectomy. We have a very straightforward. We have a strict case scenario talks about gastrectomy, and we know B12 risk intrinsic factor. So that's the link. But yes, there should be other risk factors other than the gastrectomy, which includes the dietary or nutritional deficiencies. Did I answer your question, Rukia?
Yes, thank you.
Okay, so this is not the only risk factor, right? So we got that. So other manifestations of anemia, what would be the other manifestations when patient is anemic? So patient with like, acute anemia.
This is one of my questions because it's different types of anemia, right, Professor? And
In
for
general,
example, for
yes,
for in general, it's like yellow skin, like fatigue, nausea. But for example, a plastic anemia, we can see with the lab blood work because the tree blood work is gonna be low. Those
exactly.
symptoms we have to know, we have to difference for all the anemias.
Well, it depends on the scenario. So when you're talking about the aplastic anemia, you have to go to the like white blood cells
Okay,
very low,
but you're
right?
gonna put questions like that, like difference of time of
No.
symptoms.
I'm not going to
No?
differentiate between different types of anemia. No, it will be very
Okay.
specific about, if that's a folic acid, then it's about the folate is very low in the blood, right? So, but here, for example, we have B12, then we talk about, but in general, patients with anemia usually have like a very, I would say, common manifestations. There are fatigue, right? Easily tired, dizziness, tachycardia, dyspnea. These are the common for all different types of anemia.
Lack of
Yeah.
oxygen. The oxygen is low
Yep.
too.
Exactly. It's non-specific to or
Non-specific.
diagnostic, right? Or diagnostic, but at least that most patients with anemia, they will have these manifestations, right?
And the yellow skin, right, color?
Absolutely, yes. Yeah.
Okay. What about losing weight?
I mean, weight, it will be associated with anemia. Definitely they will lose weight, yes. But weight loss will be gradual. It's not like drastic. Okay, so let's go to question number 2. So before we go to, let's just maybe clarify about the other types of anemia because Dina just mentioned that. So if we go to like folic acid or folic acid deficiency, it's usually associated with what? Who would be like at risk for folic acid deficiency? Other than you learn about like in maternity and peds course, right? About the woman who is being pregnant and they might be at risk for that, right? But other than that,
It can be like alcoholism, chronic alcoholism.
alcohol, yes, chronic alcohol intake.
GI disorders, I think
Right.
so, older.
Mm-hmm.
And what
Yeah.
about older adults? Because
Older adults because the nutritional,
until the
yes,
GI
yes,
is very slow
yes.
at the
Yeah,
age.
they will be at the bottom of the list, right?
What about
Okay,
Professor, the vegetarians people because they don't,
they
they
will
don't
be,
eat
yes,
like
yeah,
okay.
vegetarian, crash diet or dieting, yeah, diet. So that's also included as a risk factor. So 3, which is the iron deficiency, that would result also from chronic blood loss, usually like hemorrhage, bleeding, like in general, like motor vehicle accident or postpartum, or that would be like blood loss, chronic, sometimes peptic ulcer disease. That is going to, in addition to the inadequate dietary intake or iron intake, that also will be risk factor for iron deficiency. So, very similar to the folic acid. Now, the sickle cell, that's a whole different scenario, right? Because that's genetic, and you already covered that or know about this from OBP's course. Number 2.
The client diagnosed with menorrhagia reports to the nurse of feeling less and tired all the time. Which scientific rationales would explain why these symptoms occur?
And menorrhagia means it's the excessive blood loss during menses. So, what would be the answer?
Is this 4?
Number 4.
4, right? So excessive. So if the blood loss, so it's caused by That's correct. So if the blood loss is severe, then the client will have a O2 sat dropped, and the most frequent symptom and complication of anemia is fatigue. So the I think the answer is straightforward, right? Because menorrhagia usually it doesn't cause pain. Fibroids or other factors that cause the menorrhagia may cause pain. If it is fibroid, that's different. So let's go to the third question.
The nurse is caring for a client diagnosed with anemia and reduced perfusion to these extremities. Which intervention should be included in the plan of care? Select all that apply.
Okay, so the question here about patient diagnosed with anemia and the perfusion to the lower extremities, distal extremities, has been diminished. Intervention. What of the following would be? Which of the following would you include in your plan of care for this patient?
1,
We have to monitor the HNH. That's no-brainer. It has to be like number 1 always, right? So HNH for any patient with anemia.
can you move the patient near to the nurse desk? Is it because like if you have anemia, like some patient gets so dizzy easily, so it's a risk for fall.
So yeah, exactly. It's for two things. Is that with the decreased oxygenation autosat, remember that the brain cells are going to be negatively affected, and that will sometimes result in dizziness and also confusion, become confused. So we try our best to kind of wash them or have the client be observed frequently, like to be moved to the near to the nurse's desk. That's because that's a safety issue. So number 3, what about number 3?
No,
They
because
should
patient
increase. They should increase.
Yeah, exactly.
They
And
should
number
increase.
4,
There's no numbness and tingling in anemia, right? Or
there
is there?
is.
Oh,
Yes.
there is.
Yep.
There
Yep.
is.
It's a neurologic. Yeah, it's a it's a neurological changes. Yeah. And number 5,
Yes.
what about number 5?
Yes.
Yes.
Yeah.
Yes, exactly. So we can go with 1, 2, 4, and 5. Okay. Number 4, please.
The client diagnosed with iron deficiency anemia is prescribed ferrous gluconate orally. Which should the nurse teach the client?
Yeah, it's we learned also about this in the previous GI content or chapter. Patients with peptic ulcer disease, when they develop melena and like rectal bleeding.
Is it 3?
3.
Right. Yes. So the stool will be dark green, black or darkish kind of, which can mask the appearance of blood in the stool. So and all the iron supplements that are going to change the stool color, and that's, I think you know about this in from pathoform. So number 3, the stool may be very dark, so which can mask the blood. So the patients, especially patients like with peptic ulcer disease, we have to be careful with with that. If they are on iron supplement, any type of ferrous sulfate is iron. All the ferrous are iron supplements, and they kind of change the stool color to a green darkish color, and that may mask the appearance of the blood in the stool, and that's why we have to be careful with that in terms of look at other manifestations of peptic ulcer disease. But in general, we will teach them about this expected change when they take or when we prescribe them or give them the ferrous sulfate or gluconate or any type of iron supplement. Number 5.
The nurse and the UAP are caring for clients in a medical unit. Which task should the RN delegate to the UAP?
So for the previous question, what is loperamide? Just before we go to this question, what is for question number 4? What is loperamide? Loperamide, which is Imodium. The brand
Is it
name
for
is Imodium.
diarrhea? Is it for
Right. It's
diarrhea?
anti-diarrheal medication, but just to make sure that you got that concept is that the iron causes constipation, right? So iron causes constipation. So the Imodium is contraindicated for this drug. Okay, number 5, we said that the nurse and unlicensed personnel caring for a client in a medical unit, which task should the nurse or the RN delegate to the unlicensed personnel? And always remember the framework or the umbrella of the practice or the scope practice for each, right? Especially with the assisted personnel versus the RN and the LPN. So we said that the LPN, make sure that the assessment and teaching, these are the 2 major areas with LPN. Assessment, especially comprehensive assessment, and teaching components should not be done independent by the LPN. However, the assisted personnel like CNA, and that's different, right? So the answer, which task should the nurse delegate to the assisted personnel?
Is it 2?
Number 2.
So 1, the RN should evaluate the stool of a client diagnosed with melena, which so a patient has dark tarry or darkish kind of stool and blood tinged or mixed with the stool. So it's part of the ongoing assessment for the RN. However, 2, the unlicensed personnel can take the vital signs of stable patient, so the client received the blood that day before. So that is absolutely yes, number 2. So evaluation, like number 3, evaluate that. So this is evaluation task. That's the nurse's responsibility to evaluate. So the nurse or RN should know what the client eats. So that is part of the evaluation. So that's nursing, that's RN. And the last one, share the client diagnosed. So this is a client diagnosed with a severe hemolytic anemia. So this patient will be at risk because this patient most likely with the chronic and hemolytic anemia, this patient has something called pancytopenia. Pancytopenia, which is
Low blood,
everything is low.
hemoglobin
Right.
platelets and
Everything is
white
very
cells.
low. Low red blood cells, low hematocrit, low hemoglobin, low hematocrit, and low platelets. Everything is low. So RBCs, HNH, platelet. So the patient will be at risk for bleeding. So not just the infection, but also for bleeding. So that's why number 4 should not be assigned to or delegated to the assisted personnel. I'm saying this might not be real life or what you usually see in clinical. Sometimes it's not being integrated or implemented the right way or the correct way, but this so patient with hemolytic anemia should not be assigned or delegated to share the patient with that specific diagnoses, regardless of what you usually see in clinical, because sometimes you apply what you see and to answer the questions in the exam. Sometimes you have to stick to the content and to the textbook and to the guidelines as stated in the textbook. Number 6. Volunteers for number 6, please.
The client is being admitted with folic acid deficiency anemia, which would be the most appropriate referral.
So folic acid deficiency anemia, knowing what is we just mentioned this year, that this concept earlier about the high risk, who would be at high risk for folic acid deficiency anemia.
Hematologist.
Could it be A? Since we talked about
Most
alcoholics.
clients, right? Yeah, most patients diagnosed with folic acid deficiency anemia have developed anemia from chronic alcohol abuse. Remember, as I just mentioned this, I think at the outset of this of today's session, is that chronic alcohol abuse. That's the highest, who would be at high risk for folic acid deficiency. And because remember that and when you go to the mid-surge units, and especially for for these units who take care of patients with a with alcohol abuse, and they have a special protocol about that, they will include in their prescription medications. One of them will be folic acid, 1 milligram, and then B12. So this is a B1 and then B. So folic acid and B1 thiamine, and they will be on multivitamin and iron ferrous sulfate. So it'll be on CERN, but folic acid will be one of them. So folic acid is all being the group of people who are patients will be at risk for this type of anemia, alcohol abuse. So the alcohol consumption would increase the use of folate, and the alcoholic diet is usually deficient in the folic acid. So we have to refer them to the Alcoholic Anonymous. That would be appropriate. Number 7.
The charge nurse is making assignments on a medical floor. Which client should be assigned to the most experienced nurse?
Yeah. So before I go to 7, also make sure that be careful when you answer the questions about referral. Referral, when you say referral, we do referrals to certain clubs like AAA, or which is Alcohol Anonymous, and other places, but not the hematologist. The hematologist, that's a referral that should be done by who? If you are a nurse practitioner, you can do it. But the referral to the specialist supposed to be done by the healthcare provider, if that's an MD or that's a nurse practitioner. So that's a referral. We cannot, refer them to the hematologist, right? So that referral should be done by a specialized, the HCP, healthcare provider. And yeah, so number 7. Which clients, as you do the assignment on the floor or the medical unit, so which client should be assigned to the most experienced nurse?
Number 3.
So what about number 1? So the answer, what number 3 is correct, yes, but we have to provide a rationale why, first of all, for why it's number 3, and then why 1, 2, and 4 incorrect. So this is how we are going to process. Okay, go ahead.
Number one is not because the patient is diagnosed already with iron deficiency anemia, but he already have medication for that, and he's not having bad signs symptoms like pancytopenia, because pancytopenia we have to be careful with bleeding, infections, and
So okay, we'll try to dissect the question here in a different way. When you say assigned to the most experienced nurse, your rationale has to do with expertise. Why this patient should have, or why this patient should be assigned to that specific one, which is the expert nurse, right? With more expertise, not the one who is just graduated few weeks ago and hired and were and assigned to positions on the floor. So the rationale has to do with the specialty, with the expertise. why expertise is important for this specific patient. And that's how, that's why I think that the rationale has to do with this, because when we try to understand the rationale behind answers, it has to do with what is the key word from the STEM. The key word from the STEM is experienced nurse. So it's expertise. So why expertise has to do with pancytopenia. What about number one, iron deficiency anemia? Your answer to number one should say that any nurse graduated from any school should be able to take care of patient on iron supplement. So it doesn't require any specialty or any experience or any type of lengthy experience to take care of patient on iron supplement who has been diagnosed with iron deficiency anemia. So number one. And number two, same thing as diagnosed with pernicious anemia, right? B12 deficiency and on IM injections or B12, right? Vitamin B12. So number one and two, and same thing as four, that has to do with that this one or this task can be done by and performed by any nurse on the floor. Nothing to do with the specialty or with the experience. However, that the patient with pancytopenia, and that is which is a condition or situation that develops in patients who's been diagnosed with aplastic anemia, and they have everything very low. Everything should be like dropped or decreased from white blood cells to red blood cells to HNH, hemoglobin, hematocrit, platelet count. Everything is low. So this patient will be at risk for not just anemia, but it's beyond the anemia. Also, patient is severely anemic, patient's extremely tired and like fatigue, and also at risk for infections. So it's anemia and risk for infection, both goes together with pancytopenia. So this task, this patient could develop an infection or hemorrhage, bleeding, because the low platelet count as well. So it's not just the anemia, but also low platelet can result and lead to hemorrhage, bleeding, and then infections because of the low white blood cells. So given all this complicated scenario, this patient supposed to be or should be taken care of by or taken care by a nurse who has an experience. So and they may develop also other complications other than what I just mentioned earlier. So this requires that this patient needs a most experienced nurse, because the other patients can be taken care of by any nurse. Like for example, for patients with renal failure, they need EPO, erythropoietin hormone, and anyone can administer that as well. So that's kind of 1, 2, and 3, or 4, sorry, 1, 2, and 4, any nurse can take care of this, these three cases or patients, regardless if they have experience or if they just newly graduated or recently graduated from school. So, but the most experienced nurse, number 3, need that one. Number 8.
The client diagnosed with anemia reports dyspnea when ambulating in the hall. Which intervention should the nurse implement first?
So anemia, patient report dyspnea when ambulating.
Are you gonna let the patient say it first?
Remember that
I could say apply oxygen because anemia can cause lack of oxygen. Well, we can assess
Or
alone,
maybe
but
2.
how we know, because
it says
anemia,
report dyspnea when ambulating the hallway. So patient has a dyspnea when?
Ambulating in the
Dyspnea,
hallway.
it's called DOE. So you have to specify what type of dyspnea first, because before we jump to the question, we have to dissect this question, the stem, first of all, and see what is the key word within the stem of the question. The key word is dyspnea when ambulating in the hall, which means we can translate that to a medical term called dyspnea on exertion, DOE. And if you go back to the CHF or heart failure, also we found that patients also may develop that as well. So it's called dyspnea on exertion. So this patient is experiencing now dyspnea on exertion with activity, ambulation, or any type of activity that result ADLs that will result in dyspnea. So this is very common for almost like all patients with different types of anemia. They develop that. So,
Professor,
yes,
that's also shortness of breath, right? It's the same thing.
it's a shortness of breath, yes, but it's not without. It's associated with activity, associated with exertion. There's a dyspnea, what's called like orthopnea, or we have different types of dyspnea, but this one is specific to exertion, activity, ambulation, ADLs. That's going to result in dyspnea. So dyspnea on exertion, DOE. So we will get the patient a wheelchair to limit the exertion. So you see, because we sometimes jump into the answer. Oh, okay. So we'll give we'll start give or administer the O2. It's nothing to do with the O2. It's with the result. It's the factor that may contribute to the problem. The dyspnea has been resulted from ambulating. So what about if we during the ambulation to offer the patient to sit and use a wheelchair, for example, and it's going to be for a short time. It's not something chronic or long lasting, like would be lifelong, but something during the exertion. So we can offer the patient a wheelchair so we can limit the exertion. The oxygen, if you want to jump to the oxygen, the client may need the oxygen, but getting the client wheelchair and getting the client back to bed is the priority for this patient right now. And this is not something we will do it like every single day. It's just for the moment right now. First, I would do the wheelchair, and then maybe next we can do the oxygen. If the patient is still kind of auto set is still low, and we can so we can do the wheelchair and then check O2, and patients, if he needs oxygen, we can put them back to the O2. And number 3, to assess the client's lung fields. The client, the problem with this client is not pulmonary, but it's a lack of hemoglobin. And when you look at 4, assess the client when ambulating in the hall or hallway. So even if the client or we try to assess the client to ambulate, the patient still will not have the needed oxygen for the tissues. So we're not going to help the patient's tissues and cells to get more oxygen by assisting the patient to ambulate. So I think if you do, if you analyze the question that way, you will get to the answer. But when you answer the question, because first of all, we have a DOE, dyspnea on exertion. Why? So the contributing factor to this was the ambulation. So we have to think of, first of all, get the patient on a wheelchair, and then to bed, and then oxygen, and so on. So we can, I know that these type of questions are tough, but how this is the process. How would you analyze the question? Number 9.
The nurse is caring for a client diagnosed with anemia who fatigues easily with activity. Which intervention should a nurse implement? Select all that apply. Number 1, pace activities according to tolerance.
Absolutely, yes. Yeah.
We have to provide supplements high in iron and vitamins. Red blood, no, because it's not saying like more symptoms, only fatigues.
Exactly. So we will go only with 1.
2,
And
vital signs.
I'm sorry, 1 second. Number 2, number 2, provide supplement high in iron and vitamins. Do you have any specific? See, you have to answer the question based on the stem of the question. Within the stem of the question, did we specify is it folic acid, B12, iron, or we don't know, right?
So it only says fatigue.
So we can't just provide iron and vitamins because of this anemia. We don't know what type of anemia is that. What about if this patient has developed a pernicious anemia, which is B12 only. It's just anemia. This is on, we don't have anything beyond, it says just with anemia and who fatigues, right? Easily. That's all. It didn't say if this is a iron deficiency or folic acid or B12 or pernicious anemia or anything else. We don't know. But we can, so we have to answer the question based on the given scenario. According to the given scenario, I would go with anemia. All patients with anemia across the board, they will be fatigued easily and they have, right, dizziness, and we have, so that will be, so number one applies to all different types of anemia. Number two, it's specific about the iron deficiency. I mean, or yeah, iron deficiency, but we don't know if this is an iron deficiency or folic acid or anything else, right? Make sense?
Yes.
I'm not sure if I'm confusing
Yes.
your. Okay, so
Yeah,
two
that
is
makes sense.
two irrelevant. Don't answer the question with an assumption that this is an iron deficiency anemia. It could be this patient has developed a B12. So we don't know. We don't answer the questions based on what we know, or at least what we expect or what we predict, but more of what we have within the scenario. Your answer should be consistent with and limited to the scenario as described or given. Don't assume things, don't add elements, don't add other stuff, an assumption to or predicting, so answer should be strict and consistent with the stem of the question. So number one would apply to anyone with any type of anemia, right?
Yes,
And
because
yeah, exactly. Number two is irrelevant. We didn't know exactly what type of anemia patient has. And then number three, administer packed red blood cells. We don't know if this is what type
we don't
of,
know
or
how it's
exactly,
here.
right.
And
And then number four,
yeah,
vital
yes,
signs. We do
because
this every 4 hours for any patient with anemia? No,
no,
no, it's usually
okay.
not. No, it's not a practice that it should be done like every 4 hours vital signs. We don't do that. So assist with personal care as needed. Absolutely, yes, because we know that they have fatigue, general
And
weakness,
then they're
dizziness,
so
and all of that,
full.
right? And because so the answer should be based on the general manifestations of all different types of anemia, and 1 and 5 is consistent with that. Make sense?
Yes.
Yes? Okay. And number 10. Okay. All right. So who will we do here? Krisha. Krisha, do you hear me? Can you hear me? Krisha? What about Jenna? Are you there?
Yeah, I can read.
All right, thank you.
So the client has laboratory values populated in the chart. The HCP has ordered 2 units of PRBCs to be transfused. So CBC hemoglobin is 7.7 and hematocrit is 22.3. So which interventions should the nurse implement?
Good. So this is a case about blood transfusion. Patients H&H 7.7, 22.3, and we have the references in, an assumption that, we don't know if the patient is, right, male or female, but, it's very low. So, implementation, what would you do?
Obtain assigned consent,
Yes,
assess the client's lungs, and check for allergies.
and check for allergies. So, like would be 1, 3, and 4, right?
Yes.
What about 22 gauge IV?
No, isn't it 20 and 18 is preferred?
Right, exactly. So 18 is the best. If you don't have it, 20 is fine, which is a little larger than 18. That's because many blood products they require at least that, I would say 20, even 18 is better. So because the size of the red blood cells, because if you choose smaller than 20, like 22, 20, 23, 24, or 25, that's going to result in that the red blood cells are quite large, and that's going to result in destruction of red blood cells, like hemolysis. You can hemolyze and destroy the blood cells. red blood cells. So, so we said number one, the client must be given permission to receive blood or blood products because the nature of the potential complications. And then number three, that's to assess the lungs because we are given blood fluids, IV fluids, which is blood and IV fluids can cause fluid volume overload, and we should assess for the heart failure. And the lung sounds or lung assessment includes auscultating for the crack, any crackles, and other manifestations of the left, especially the left side heart failure. In addition to, we assess for the JVDs, we assess for the peripheral edema, and as well as for any hepatomegaly for the right side failure. And number four, we check for allergies, and that's important also as well, significant task, because when we administer any medication, we have to check for allergies, including the blood transfusion. So, and some medications are administered also before blood transfusion, especially patients who tend to have a previous allergies or reactions to any blood transfusion in future, like, blood transfusion sessions or times, then we will pre-medicate the patient with Benadryl IV and Solicardiff, which is steroid IV. So steroid and Benadryl anti-allergic medication and anti-inflammatory drug will be given intravenous. That's pre-medicated. This is which is before the blood transfusion for any future transfusions, because anytime patient has developed any reaction, then in the future we will pre-medicate the patient with these two meds, and especially the anti-allergic medication like Benadryl. The IV fluid D5, usually we keep the IV, the normal saline, right? We said that the normal saline, not the D5W, because the D5W, why do you think we shouldn't be hanging any, or because when we do the white tubing, we can on one side, or the tubing will have blood product or unit or bag. On the other side, we will have IV fluid, which is always normal saline, 0.9% sodium chloride. What's the rationale for, or why the D5W is contraindicated to be hung or mixed with blood transfusion or with blood when we do transfusions?
I believe because it will make the red blood cells to hemolyze.
Yes, because D5W can result in the hemolysis of red blood cells when it's mixed, right, in the white tubing, and that's very dangerous because that's result in hemolysis. That's why the only fluid that should be hung with blood transfusion is normal saline and nothing else. 11.
The client is admitted to the emergency department after a motor vehicle accident. The nurse notes profuse bleeding from a right-sided abdominal injury. Which intervention should the nurse implement first?
So you're in the ED, emergency department. There's the MVA case or status post motor vehicle accident, and there is a profuse bleeding from the abdomen.
Is it 2?
Rationale?
Because if the patient is profusely bleeding, you might need to give them blood products. So you put in the 18 gauge needle and
right.
Yeah.
Yeah. Good. So the first action is, in this situation, is that the client has lost a lot of fluid loss, which is blood loss, that is to be replaced as quickly as possible. So number 2. Number 3, laparoscopic, which is to sign for consent for exploratory laparotomy, which is a surgical procedure here. The client will probably need a surgery to correct this, because that's resulted in, which is a source of bleeding, which is the abdominal injury. But stabilizing the patient or client at this point with fluid resuscitation, that is the first priority for this patient. Before we go do anything else, we have to initiate the IV, catheter or like access to patients so the patient can receive the fluid replacement or blood transfusion, and especially first the fluid, and then later on patient can receive the blood transfusion if need be. So sometimes you have all four options are correct, but which one is first? Or should be like implemented first, or which takes priority at that time. Number two is priority for this patient. 12.
The nurse
The
is
nurse
what?
is
You can go ahead, Lena.
okay. The nurse is working in a blood bank facility, procuring units of blood from donors. Which clients would be candidate to donate blood? Select all that apply.
Okay, this is a great question because this has to do with the blood products and the criteria for blood transfusions, who should receive. Who can donate blood products and who can. So in this case, we are going to say which client would be candidate for blood donation. And you can exclude those who should not be or unable to or should not be donating or should be banned from, and that will be determined by the blood bank as well. So what about number one? So we're going to select those who, or candidates who can donate blood. Number one, can donate blood?
Answer now.
Why? What? How much blood loss you can get from the wisdom teeth removed? And even that's a week after. It's nothing. Very negligent, very small amount of blood loss. Very small. It doesn't, result in to be like a criteria to be excluded from blood donation. So you can give blood. So number one is very small, tiny, scan amount of blood loss. It doesn't contraindicate you from giving, donating blood. So number one, you can, yes. Number two. Number two.
Is the nursing student already immune to rubella after 2 weeks?
After receiving rubella immunization 2 weeks ago, it should be 1 month.
Okay.
So after rubella immunization, that individual client or individual cannot donate blood for 1 month after the immunization. Okay, so so number two is not eligible, right? Until it's like 2 more weeks, right? So after a month, they can. Good? So we still are we will go with number one. What about number three? I mean, look at this as a real life scenario. I mean, don't be talk like too much about the speed in terms of be realistic at the same time. Like wisdom teeth, I mean, who would lose 2 or 3 liters of blood from wisdom teeth removal? It's a very small amount of blood. It's nothing. It's not even going to be recognized as blood loss. Number two, we know why, right? That's rubella immunization, so it's like a month. That's recommended. We know, and we covered that also in OBP's course. Number three, a mother with 6-week-old newborn. 6-week-old newborn. So had a baby
No,
like a
No.
1 month, 1.5,
no,
right?
because
I
she
don't think
just
so.
I mean, we don't
She's
have anything to say about the mother who had a baby 6 weeks ago if there was a postpartum hemorrhage or there was any type of significant blood loss. So um, number 3,
number
this
3,
client,
no,
yeah,
No.
she cannot
okay,
name.
all right. So the time frame, so that's why we have to go over time frames here. So for rubella, it's 1 month. After 1 month, they can, right? For the postpartum, it's 6 weeks, and it's 6 weeks or more or over, they can. So it's up to 6 weeks. And let's say in the exam, I would say I changed that to be a mother with a 2-week-old newborn. It is contraindicated. No, she cannot donate blood. 6 or longer or more, then they or she can. So
But number 3, she can donate.
yes, 6 weeks, yes, but less than 6 weeks, no. So this one can donate blood, yes. So we are good with number 1 and number 3. What about number 4?
Yes.
Patient who has a allergy to the acetylsalicylic acid, like the aspirin in childhood, yeah, they can. Nothing to do with, right? With like transferring that to others, no. So they can, right? So they can. So 1, 3, and 4, they can. What about 5?
I
Who
think
got
no,
a
because I think we
No.
have to wait like 1 year, I think so.
tattoo 6 months ago? The client with tattoo must wait 3 months, three, not 6 months, right? So 3 months to donate blood if the state where the tattoo was applied is not regulated. So if it's not regulated, then we didn't have, but we will always, let's just stick with the 3 months for now. We have like, I think states, yeah, I believe like Georgia and Maryland and others, but we don't. Yeah, let's just stick with the 3 months. So as long as we have to 3. So 6 months is fine, unless it's kind of dictated by the state regulations. That's different. But the tattoo for us it's 3 months, and it so beyond 3 months, yes, they can, right? So 5, yes, they can do blood transfusion, and then 6, give blood 6 weeks ago. So we have to wait how long until we can redonate or donate again? So like time lapse or time between donations should be at least 8 weeks, 2 months. 2 months between donations. Okay, so 6 weeks, no, not good. And what about number 7? Patient received a immunization with COVID-19 vaccine 2 days ago. Can that patient give who had received the COVID-19 vaccine 2 days ago?
Do you need to wait more days because 2 days is so recent?
Nothing to do with the vaccine. As long as the patient is a symptom and fever-free, they can. As long as nothing to do with the vaccine, they can receive it today and same day, as long as they are symptom and fever-free, they can. So if vaccinated with a live attenuated this is RNA based. But if they are for those who sometimes they receive attenuated COVID-19 vaccine, they will wait 2 weeks. I know that you should be prompted to know the difference between the RNA based or the attenuated one. But if the live attenuated is different. This one, you can give it anytime because it's not live attenuated, but live attenuated COVID-19, that a patient should wait 2 weeks. But again, I won't include that in the exam unless have prompted you to know the difference between these two, the RNA based or the live attenuated. So this one is okay for 2 days, but if it was a live attenuated, then they have to wait 2 weeks. So far, we have those who can donate blood are 1, 3, 4, 5, and 7. 13. This is a good application question about the different blood groups and who should receive what and contraindicated from receiving blood, like specific blood groups. Who did we did not hear? Andre, please. Are you there, Andre?
He texted, he said he's at work.
Okay.
I can read if you want.
Professor, and
Yes.
at 7 I have to leave. Okay, Professor, I'm so
Yeah, no
sorry.
problem. Yeah. Dianara? Anyone?
The client with O positive blood needs an emergency transfusion, but the laboratory has no positive blood available. Which potential unit of blood could be given to the client?
So O positive blood. That's the patient, which is recipient. So we didn't have an O positive. What would you give the patient? And it still will be safe blood product to be transfused to that patient. So this patient should receive one of the following: O negative, A positive, B positive, or any RH positive unit.
Is it O negative?
So yeah, so I think which what I meant by 4 is that patient can receive RH positive, like A positive or B or AB positive, any blood group with RH, right, rhesus factor positive, but the O positive cannot receive A positive or B or AB, right? They can only receive O. And when it's O positive, they can receive O positive or A negative because they are already having the positive rhesus factor. But if this patient was an O negative blood group as a recipient, then they should not be receiving O positive. They can receive O negative only. So O positive in the scenario, they can receive either O positive or O negative only. But if that patient is an O negative, they only can receive O negative, and they cannot receive O positive. 14.
The client is scheduled to have a total hip replacement in 2 months and has chosen to prepare for autologous transfusions. Which medication would the nurse administer to prepare the client?
So total hip replacement in 2 months, and patient autologous. You know what is autologous transfusion, right?
Yes, Professor.
Okay, so yeah, so they store their own blood, units and in preparation for future surgery. So which medication would the nurse administer to prepare the patient? Medication has to do with anemia.
So fall, Professor?
It's epoetin. That's the only medication,
Epoetin.
epoetin alpha. Yeah,
Yeah.
which is Epogen, that's Procret, that's biologic response modifier, which is erythropoietin and EPO hormone. That's a form of EPO, that's substance that's going to stimulate the bone marrow to produce the red blood cells. So, I mean, client may be prescribed iron preparation, like, iron like supplements to prevent the iron store depletion of the iron stores. And so we can like give the patient or prescribe them EPN, erythropoietin hormone. At the same time, IM or sub-Q. At the same time, we can do also in conjunction with iron supplements. And the blood or a unit of blood, it can be withdrawn once a week, beginning at 6 weeks before surgery. So this is like the protocol type of plan for this patient. We are going to put them on EPO and alpha in conjunction with the iron supplement, and we are going to withdraw the unit of blood once a week, beginning at 6 weeks before surgery. And no phlebotomy should be done within 72 hours of surgery. So before the surgery, 72 hours before surgery, no phlebotomy should be done. And this is the protocol for the autologous transfusions. 15. Dayanara, ready? Dayanara?
I could read, the client undergoing knee replacement surgery has an autologous blood recovery apparatus attached to the knee on arrival to the post-anesthesia care unit. Which intervention should a nurse implement to care for this drainage system?
Mm-hmm. Okay, I'm just reading some of the chat messages. Okay, so 15, undergoing the hip replacement or knee replacement surgery.
Can be, I don't know, Professor, maybe 2, no, trainees collection bag. I don't know, 2.
Yeah, you remember how the blood transfusion is kind of designed or structured? You have the bag, and sometimes you have like the pressure bags around it, and you will like inflate so you can maximize or increase the flow of blood through the tubing. So
Oh.
yeah, maybe I think
Professor.
number one, yeah, will be number one. So we have the thing to read more about the autologous transfusion, and it's I believe it's under the blood transfusion as well as it's under the hip replacement and total knee replacement as well. But the autologous blood recovery apparatus, which is like the setup or whole thing, that's a device that is going to catch the blood loss during the orthopedic surgery. So that will catch the blood that's being lost during the surgery to being reinfused into the client. It's like a process, like one of the apparatus, which is like a device and it's a system, rather than giving the client donor blood product. They will be reusing their own patient's blood product. So the cells are washed with saline and reinfused through the filter into the client or patient again. So kind of we are reusing the patient's blood after being filtered and washed and filtered with saline, normal saline, and being reinfused back to the patient. So these salvaged cells cannot be stored and must be used within 4 hours or discarded because of the bacterial growth. So that would be number one. I mean, number 2, attach an hourly drainage collecting back to the unit. Number 2, it says that the cell, the device itself, it's a measuring device. So it's an hourly drainage bag is part of the urinary drainage system, not the blood. So this is different than the urine. So number 2, like pertains to a different drainage system. That's the urinary system. And number 3, the patient or the PACU nurse and the post anesthesia care unit, the nurse in that unit would not replace that system. It is inserted into the surgical wound. So the CPM machine, remember that the CPM machine we just mentioned post knee replacement? So the CPM machine can be attached to the outside bandage. Remember the CPM machine that has to do with the extension and the knee flexion and all that. This is external. It had nothing to do with the blood transfusion. So it's irrelevant to that, to the question or to the blood transfusion. And number 4, have another nurse verify the unit number before reinfusing. The blood has not been cross-matched. So there is no cross-matching number. So we don't have, that's usually number 4 will be done when we have a recipient and a donor. So we have patient being receiving, or patient is receiving a donor's blood unit, but this patient is receiving his and her own blood product. We are reusing the patient's own blood. So there is no need for cross-matching or number 4. That's why number 4 is incorrect. So number 1 is correct. I think maybe, this concept might be a little difficult because we did not cover that in class, but at least I recommend that you study maybe more from the book about the autologous blood transfusion or autologous blood. Number 16.
Which statement is the scientific rationale for infusing a unit of blood in less than 4 hours? Uh, 3.
So 3, the blood components begin to break down after 4 hours. Not necessarily in terms of hemolysis, doesn't take place because of the time frame or because of the length of time or time after 4 hours. It's about the
Is it 2?
it's right. It's more the bacterial growth has to do with that. So because the blood is a great medium for bacterial growth. So any bacteria contaminating the unit will begin to grow if left and outside of a controlled like environment longer than 4 hours. So blood unit longer than 4 hours, we will allow for any bacterial growth to grow, and that will be at risk for patient will be at risk for septicemia. Yeah, the coagulation, it doesn't take place like number 1. It said coagulate, the blood will coagulate. The blood will coagulate if left out of an extended period, but the blood is stored with some citrate, for example. The citrate is one of the preservatives that would prevent that coagulation and will prolong the life expectancy of the blood. So there are some preservative substances or chemicals like citrate, one of them, and that will prevent coagulation, even outside of the fridge. And the blood, the last one, 4, is just I'm going over why 1, 3, and 4 incorrect. 4, it said the blood will not be affected. This is a lab procedure. So, I mean, these are standard nursing and lab procedures, both, to prevent the complications of septicemia. It's not just the lab responsibility, but also our responsibility to take care of patients and to be an advocate and prevent septicemia and infections um, for our patients. 17.
The HCP orders 2 units of blood to be administered over 8 hours each for a client diagnosed with heart failure. Which intervention should the nurse implement? I think it's A because it should only within 4 hours.
So 2 units of blood, 2 units to be administered over 8 hours each, 8 hours each for a client diagnosed with heart failure. So and remember that sometimes we have patients who cannot tolerate the amount of blood because of heart failure, because CHF, because they may develop an overload, fluid overload. So the healthcare provider orders, or I mean, the healthcare provider has an orders or written an appropriate order for this client diagnosed with heart failure. And it doesn't need to be called to verify the order before implementation. You don't have to call them.
So would it be 3?
Yes. So 3, notify the lab to split each unit into a half unit and infuse each half for 4 hours. So given that we have a specific order already prescribed, given or like written from the prescriber, from HCP, healthcare provider, done, then we can discuss it with the lab, staff or people in the lab about the mechanism and the tactics of what would be the best and safest methodology and way to administer this blood transfusion for this patient. So the correct procedure for administering a unit of blood over 8 hours is to have that unit split into halves. Each half of that unit is going to be treated as a new unit and checked accordingly. So this slower administration allows the compromised, because this patient is going to be, we will label that patient as a compromised patient or client because they have a CHF. They cannot tolerate that amount within that time frame. Otherwise, they will, result in or lead to CHF or heart failure or like decompensation of the heart failure. So we can split that, treat each half of the unit as a separate one over 4 hours, and we can prevent the fluid volume excess or overload for that patient. Any question about this? About this question? Any comment, anything?
No, Professor.
Okay, 18.
The client receiving a unit of pre-red blood cells begin to chills and develop hives. Which action should be the nurse first response? I think is to stop the infusion.
And why?
It's like a reaction to the blood, Professor.
Right. So priority for in this situation is to stop the infusion, so we can prevent, right, further reaction if that's going to happen or possible. So stopping the transfusion and changing the fluid out at the hub will prevent more transfusion from entering the bloodstream, and we can prevent any further reactions to happen. Any question about the other stuff like 1, 2, or 3? Why number 1 is incorrect?
You have The question is asking what's your first response.
But
So I think
but what about number one? If this is like the first time this patient developed a reaction, this is the first time patient had developed this reaction, would you call the PC? Would you call the prescriber, like the PCP or doctor or nurse practitioner, the provider?
You would call them, but you should stop the transfusion
So
before you
exactly,
think to call them.
right. So we will. So prioritization, like ranking, I would stop the infusion, and number two, call the PCP. We have to call them. This is the first time this patient has kind of developed this type of reaction. We have to call them, but after we stop the infusion. So after transfusion cessation or stop the transfusion, you can call the PCP because they are going to prescribe medications. So you cannot just administer the, you can do it like number three, because you will get these prescriptions or medications be prescribed for this patient, like which is diphenhydramine, which is Benadryl, as well as sometimes they add also the steroid like solomedrol or serocardef, which is methylprednisolone, in addition to the Benadryl IV. So 19.
The nurse is caring for a client diagnosed with sickle cell disease. Which should the nurse include in the client's plan of care? Select all that apply. 2,
Right.
interventions to maintain
Hydration, always
hydration.
number one. Hydration status to prevent the sickling, right?
3, measure the
Attack.
client's 3, measure the client's
Now,
calf for swelling.
3, measure the calf for swelling. Swelling from the sickling cells usually occurs in the joints, not
Okay.
into the organs. Yeah. So
Um,
measuring the calf would assess for DVT, but not for sickle cell, right?
mhm.
And
5.
then 5, right? So hydroxyurea, which is the FDA approved drug for reduction of the painful sickling episodes. Yeah.
So
So
just
1
2
and
and 5.
2 and 5, exactly. Yes. 20.
the client diagnosed with SCD is experiencing a vaso-occlusive sickle cell crisis secondary to an infection. Which medical treatments should the nurse anticipate the HCP ordering for the client? Select all apply.
So the healthcare provider would prescribe which of the following for this patient who had developed a vaso-occlusive sickle cell crisis, in which that, you know, how the sickle cell anemia patients with this disease and pathophysiology flows that there will be clumping of these red blood cells and how to occlude even the blood vessels. So that's what vaso-occlusive sickle cell crisis, in which that there is an occlusion in the blood vessels. So the what about Demerol, metherdine? Demerol, the metherdine, which is Demerol, it's not given in sickle cell crisis to control pain or recommended for long-term pain management because if we said that morphine is a drug of choice for these patients for pain management, morphine is a drug of choice for sickle cell disease patients for pain management, but not meperidine Demerol. Demerol is the brand name. Why meperidine is not good? It's contraindicated here because meperidine, first of all, it's contraindicated for 2 groups of people. Older adults, try to avoid prescribing meperidine to older adults, and to sickle cell disease patients. Sickle cell disease, and same thing for older adults, because the meperidine, the byproduct from the metabolism of meperidine results in what is called the metabolites. It's like toxic metabolites, and these metabolites Again, they are very toxic and that can result in seizure attacks. They can develop seizures. So patient can develop seizures. So if that's older adults or sickle cell disease, that's why morphine is the drug of choice for patients with sickle cell disease. So number one is contraindicated. Number two, admit the client to a private room and keep in reverse isolation. What is reverse isolation, by the way? Reverse isolation, which is same as, what's the other name for reverse isolation? And I don't like use word isolation. Usually I would say reverse precautions. Remember the airborne precautions and droplet precautions, contact precautions, or isolation, right? So what is reverse isolation or precautions? It's the same as, what's the other name of reverse isolation or precautions?
I don't know the name, but I feel like the reverse isolation is you would put the patient the protective gear instead of the nurses.
Professor, I don't really know the name of it, just like trace, but I feel like it's when the patient has like very weak immune system.
Thank you. So it's reverse isolation, because remember that all different types of isolations, we are going to put the patient in a private room, not to isolate the patient, but in a private room in terms of, you can use, you can say isolation, but it's a private room because the patient has an infection that can be infectious to others, TB, pneumonia, and others. So contact, C. diff, or TB, the airborne precautions, pneumonia or flu, droplet precautions. These are type precautions because, or isolation, because the patient has an infection that can be infectious to others. With the reverse isolation, the other name is called neutropenic isolation or neutropenic precautions. It's different from all different types of isolations. It's reversed. In other words, that how would you translate that reverse isolation?
Is it protecting the like you're
Protecting the patient, right?
Mhm.
So it's not, the patient doesn't have an infection that is infectious to others. It's reversed the other way. That the patient has no infection. Patient's immune system is compromised. Patient white blood cells is less than 5,000. Patient has a significant drop in H and maybe everything like pancytopenia. Patient has a significant drop in neutrophils. So that's the reason why this patient at risk for, so immunocompromised patients with significant immune system compromise or deficiency put the patient at risk for infection. So they will be in like in a private room, something called reverse isolation. The other name is neutropenic isolation or neutropenic precautions, because it's completely different from the other type of precautions, flu, C. diff, or TB, or other, or shingles, or because all other types of precautions is because patient has an infection that can be dangerous to others, like can transmit to other patients and employees and staff. But in this case, it is that the patient has no infection, but at risk for infection, and that's why we'll put the patient. So it's kind of prophylactic and protective to the patient because they have a very low immune system or immunocompromised system. So the patient, so number two, it's irrelevant, right? So patient doesn't need reverse isolation because other people will not affect the crises. Number three, yes or no? Vaso-occlusive sickle cell crises. Number one, for management of patients with sickle cell disease, especially the crises episodes like this from OB-PEDS or PEDS course. Number one, nursing management. The first thing you would do.
Fluids.
Fluids.
Give fluids.
Yes, exactly. So 3 would be great for this patient, which is usually given to a patient here at speeds, and we go with the 1/3 of normal saline, 150 mLs an hour via pump. That's number one. Has to be like the first intervention for this patient, especially during the vaso-occlusive crises. And what about number 4? There is no reason unless patient has a Foley catheter. That's different scenario. But we didn't. No need for the Foley catheter. No need. What about number 5?
Yes.
Yes. So number 3 and number 5. All right. 21.
I'll read. The nurse is completing discharge teaching for the client diagnosed with a sickle cell crisis. The nurse recommends the client get the flu and pneumonia vaccines. The client asks, "Why should I take these shots? I hate shots." Which statement by the nurse is the best response? Mm,
I think 2.
And can you provide the rationale for that? Why do
because
you think? Yeah, can you
well,
provide
because
anything? Yeah.
like when you have sickle cell, like
Mm-hmm.
you're more at risk for infection,
Mm-hmm.
and that can trigger a crisis.
Right. It's about the immune system infections and so on, that kind of concept, but it's very specific to the spleen. Very specific to the spleen. So clients with sickle cell disease, they have a reduction in splenic activity. The spleen is very fatigued and very inactive. So that's about the spleen. So splenic activity is very reduced from the infarctions, the blood clots during the crises. Every single, over a crisis, patient will develop more issues with the spleen, and it will result in more detrimental effects on the spleen. So they result in a significant reduction of splenic activity. And this situation progresses to the spleen no longer being able to function. So that would increase the client's susceptibility to the infection. So it's about the immune system infections, susceptibility, or predispose the patient to infections because of the spleen as being involved in every single crisis. The spleen gets less or reduced function and activity, and that's why a patient will be at risk for infection because the spleen is part of the immune system. So So 2, yes, is the correct answer. And usually, I mean, the vaccines, they have nothing to do with the sickle cell in terms of the prevention of sickling of the blood cells. And number 4 said the doctor wanted to make sure that I discuss the vaccine with you. Teaching the client is an independent nursing intervention or task. So the nurse doesn't need to rely on the HCP or provider to designate what should be taught to the patient. We can do that independent from other prescribers or providers. Number 22.
A family member brings the client to the ED reporting that their 78-year-old parent has suddenly become very confused and thinks they are living in 1942. They must go to war and that someone is trying to poison them. Which question should the nurse ask the family member?
Okay, let me just go to the stop the recording because it's going to be very long. It's been like 2 hours now, right? So let's see if I can do that. So to stop and then restart.
And we have two more modules to go over, Professor.
Yeah, but the most of the questions, it's about the blood transfusion. A very few about Alzheimer's and pain management. But so we'll continue. Actually, I will continue. I have few questions left. So 22, it's about the Alzheimer's dementia. 78 years old parent suddenly became very confused. Which question should the nurse ask the family member? And this question is a good one because that differentiate between sometimes we get confused between and we go back and forth as dementia, like delirium dementia, which one is what? Dementia involves, when you say dementia, without not knowing but let's just put the definition first. Dementia involves the irreversible behavior changes that will occur over time. Now, delirium usually occurs like sudden. Delirium is sudden onset as and it's usually caused by an acute event. So dementia involves irreversible behavioral changes, and that's kind of accumulate over time and increase and escalate over time. However, the delirium, it is more of a sudden onset and usually caused by the underlying causes. There are sometimes an acute event that may precipitate this delirium. And usually it's reversible. As long as we identify the contributing factor to delirium as, again, it's an acute onset, and it's usually reversible delirium. And also it can be reversed once we stop and control the underlying cause. So it's usually caused by acute event. And you will find from the PowerPoint slides about the different risk factors for delirium and how it's different from the dementia. But this is the significant, I would say, definition and the differentiation between dementia and delirium. So, number one, has your parent been diagnosed with dementia?
Professor, is it 3?
Professor, I think it's 2.
Yeah, is it
Okay.
two?
So one, I already explained about number one, why it's incorrect. Now, number 3, what have you given your parent that makes them think it's poison? How would you feel if a nurse would tell you that?
Bad.
Yeah.
What
It's
does
like you're
what does that what does that mean? How would you perceive it as what?
it's like you're accusing them.
Exactly. It's like the blaming. Yeah, it's a blame. So it's a blaming the family member for the client's paranoid ideation. So, and number 4, does your parent like to watch old movies or on television? So, watching old movies and television will not cause delirium. So that's why the reason why number 2 is correct. If the drug toxicity and interactions are the most common cause or etiology or cause of delirium in older adults. So older adults, most of the time, they develop delirium, and the drug toxicity and the interactions between drugs is the main causative agent or factor that may predispose patients or older adults to develop delirium. So that's why number 2 is correct. Okay, number 23. So the older male client is admitted to the medical unit with diagnosis of dementia. Now the client is 70 inch. That's the tall. How patient is tall is patient, and the patient's weight is 120.2 pounds. The client lives with his son and daughter-in-law, and both of them work outside the house. Now you're going to refer the or what type of referral is most important for you to implement? What type of referral is important at this point? When would you refer them to number one, adult prospective services? I mean, sorry, protective services, APS.
He's malnourished.
Yeah. So, I mean, APS would be consulted. Actually, Leo, is that or called when? When do you think?
When there's neglect or abuse.
But exactly. And so that's that when we have decided and determined, I would say determined that this patient is being neglected. But we can't just deduce from these findings that patient is being neglected, right? Maybe, appetite is poor appetite that could result in that, or we don't know. So the APS, the Adult Protective Services, would be called or should only be called if willful neglect or abuse of the client is occurring. So if you had decided to determine that patient is being neglected, being abused, that's when you are going to call the APS. However, that we don't have a full, at least from this scenario, how, if the patient is being neglected. So it looks like patient is, not well nourished, maybe, and it's not settled that, because they are both are working outside the house, but we don't have a full information, detailed information about, the reason, or at least that this is a willful neglect or abuse. So number 3, the Medicare ombudsman, that's they represent the Medicare clients in long-term care facilities. They will be responsible for the patients in the LTC, like nursing homes. And then number 4, dietitian could see the patient to determine the dietary preferences or food preferences. But the most appropriate intervention is safety for this patient. So the most appropriate now, the most concerning priority for us now is safety. So we should arrange for the social worker to see the client and family, to sit with them, to have a meeting to determine if arrangements could be made to provide the client or provide for the client safety, and the client to be provided with, because there are a lot of resources, options, things can be done, Meals on Wheels, or there are a lot of programs out there, right? To feed the older adult client. So even at home, so that should be done by meeting with the social worker. So the long-term care facility or adult daycare may be needed at this point. So social worker will be the best option. So 24.
The home health nurse must see the following clients. Which clients should the nurse assess first?
So if you work like as a home health nurse, and you're going to see 4 patients, or you have previewed the 4 cases, and you would like to visit the first one to visit, who would be the first one? And always it's unexpected, unpredicted, or things unusual, like either manifestations or unusual or complication or unusual symptoms of a certain disease. That would be always the first one. So if you go with the first option, the T-tube, right? Patient post-op with the T-tube after cholecystectomy, is that something expected? Green drainage and T-tube post cholecystectomy?
Only for the first day, no?
Yeah, it is expected. They'll say, we don't have specific, what is it, post-op from. Yeah, even few, it will be for a few days until T-tube is removed. Until the T-tube is being removed, we expect that. The greenish drainage, that's a bile product or bile secretions. So what about number 2? Yeah.
Isn't it can it be number 3 or no?
Yes, exactly. Yep. So number 2, the client diagnosed with CHF would be expected to experience these symptoms of exertion, like DOE, dyspnea and exertion and other symptoms of CHF, expected. But number 4, if you go to number 4, for example, being diagnosed with end stage like liver failure, like end stage liver disease, ESLD, or in other words, we call this liver cirrhosis. Um, Gaining 3 pounds, that's expected. And because we know that patient will develop a fluid retention, and there will be a loss of protein. There's a lot of protein loss, and there is fluid retention. So the weight gain is expected because of fluid retention in liver cirrhosis or liver, like end-stage liver disease. But number 3, coffee ground MSS indicate there is a GI bleeding, and that should be seen first. 25.
A patient with Alzheimer's disease has had increased evidence of dementia and physical deterioration. What would be the best assistance to recommend to the caregiver's spouse who is exhausted?
To give them like to provide them some type of relief, or time off of this responsibility, which is 24/7. Give them some type of vacation, and sometimes can be like a few hours a day.
Would it be 3 or 1?
3, adult daycare would be a great one. I mean, long-term care would be for long-term. If that's kind of a daily basis would be adult daycare, because they provide a daily, the adult daycare, they provide social, health-related services, recreational, even culture, also congruent, services in a safe community-based environment. And that would keep the patient safe and would decrease also the stress on the caregivers and the husband in this case. So the long-term facilities or long-term care, that is when the patient has a rapid deterioration, the caregiver is unable to continue to provide care. That's long-term care. But on a daily basis, to give them some type of like short vacation daily off the, not taking care of like 24/7, from 8 to 1 or 8 to 2, every day, that would be adult daycare. The home health care, that's used when there is a supportive caregiver involvement for patients with health needs. And the homemaker services provide like services, but they do not usually provide care for the patients, but more of just kind of home health services. 26.
A client with Alzheimer's dementia is being admitted to a long-term care facility. The client is widowed and previously lived at home alone. Which person would be acceptable to sign an advanced directive specifically with regard to resuscitative orders on behalf of the client?
Like legally, which one would be responsible or able? I mean, legally can do the advanced directive, sign for advanced directives, and especially for the code status, right?
Number
3. Yes, exactly. So because the advanced directives is written document that is recognized by the state law that will provide directive or like directions concerning the provision of care when the client is unable to make his or her own treatment decisions or choices. And the two basic types of advanced directives, they involve like the living wills and the durable power of attorney, the POA. So in terms of resuscitative orders, if the client is unable to make decisions, unable at all making any decisions, so if the power of attorney, the POA, had not been previously appointed by the client, the next of kin will make decisions with regard to the healthcare services for that client. Therefore, the client's daughter would be the acceptable one legally to sign the advanced directives for this patient. Now, The Alzheimer's dementia, it's like option one, patient cannot, right? Should not be doing that. And option two and four, um, because the members of the healthcare team cannot make decisions for clients. And there are a lot of scenarios around this. Sometimes the client can be conserved by like the state. Like the state has, like conservator, from the state, designated from the state. So there are a lot of options, but for this specific scenario, would be that the client's daughter is the one who can sign for the DNR or like coded status for that patient. I mean, what I meant is advanced directives. 27.
The nurse understands that clients who are mentally or emotionally incompetent are unable to sign informed consents for themselves. Which conditions indicate that a client is mentally or emotionally incompetent? Unconscious,
Unconscious, yes. Chronic dementia,
dementia,
yes, right? And
declared
then
incompetent,
declared incompetent, absolutely, yes. That's
and
it. Yeah,
okay.
that's it. Yeah. So the clients who are mentally or emotionally incompetent would include like the patient is unconscious, the client with a chronic dementia or other medical deficiency that impairs thought processes and ability to make decisions. So it has to do with the chronicity of the condition, any medical condition, not just dementia, any medical condition that may negatively impact the thought processes and the patient's ability to make the decisions. Sound decisions. So a client has been declared incompetent. And a client who is under the influence of chemical agents like alcohol or drugs or certain medications also will be incompetent as well.
Yeah, I was gonna ask that. Can't that alter like their mental status too?
I'm sorry?
I was gonna ask
Yes, exactly.
why
Yes.
wouldn't it alter their mental status?
The ultra mental status, because that depends if that's occasional or like in terms of like episodic, because sometimes the ultra mental status as AMS, it's not a condition that may determine that patient is incompetent, because sometimes it's episodic. Like for example, patients with liver cirrhosis, at some points they will develop that altered mental status because they will have ammonia level would rise and affect the brain cells, and they become very confused, and at some point maybe
So
comatose. So it's not
So
um,
we would only choose that answer, the influence of chemical agents, if they specify the drug and that drug causes like sedation or
yeah.
confusion.
So, for example, if you put patient under sedation, you are not going to. They will be considered, yes, they're incompetent. They are incompetent because you see they are sedated completely.
Right.
So here, we remember the influence of chemical agents is more of they under the influence of alcohol, drugs, certain medications. So if you are like, if they are under general anesthesia, for example, right, they're incompetent, definitely, right? If they are under, like, if they are under the performance or undergoing a lithotripsy and they are in conscious sedation, you can ask them to sign something. They been receiving the propofol and other medications. They are because they're under the chemical, an influence. So under the influence of chemical agents, that includes medications, chemicals, any chemical like alcohol, drugs, medications. That's so 1, 2, 3, and 5. 1, 2, 3, and 5. Good. Um, 28.
An older adult client states to the nurse, "Lately I'm getting forgetful about things. Do you think I'm getting Alzheimer's disease?" Which response by the nurse is most therapeutic? 3.
Oh, yes. Yes. So Alzheimer's dementia, that's characterized by a syndrome of symptomatology with a slow and insidious onset. And generally, the it progresses. It's like in terms of progression of the disease process. It's very progressive and deteriorating course. It's like takes It's over time, like it's a lengthy process. So if you look at like number 1 and 2, you will find that the nurse gives false reassurances, which would devalues the client's feelings and discourage the client from expressing their feelings. And if you look at number 4, or option number 4, the nurse makes a I would say non-professional, which is unprofessional, which is a personal comment, and it will belittle the client's concerns, which will discourage, again, the expression of feelings. So, number 3, 29.
A client who is diagnosed with dementia becomes increasingly disoriented and confused at night. Which interventions will the nurse implement for this client? Select all that apply. Use a nightlight.
Mm-hmm.
Provide a consistent nighttime routine. And
That's it.
That's it, right?
So it's important to provide consistent daily routine and safe, low stimulation environment when the client is disoriented. Now, noise, including radio and TV, may add make the confusion even worse. So it may add to the confusion. The noise, like the radio or TV or that kind of stimulation. So it may make the confusion and disorientation even worse. Allowing the client to have visitors during the night hours and reorienting the client every 15 minutes is very disruptive.
Mhm.
Okay, 30.
The nurse is caring for an agitated older client with Alzheimer's disease. Which nursing intervention will most likely calm the client? Is it
So
2?
is the patient, so now patients with Alzheimer's, usually we say Alzheimer's, but we add dementia, we'll say Alzheimer's dementia. So Alzheimer's dementia, Alzheimer's disease, patients is not a good candidate for group work, especially when they develop agitation. When they are agitated, they are not a good candidate for group work. So number 3 should be an automatic, right? Distractor. So the nursing interventions for the Alzheimer's clients who is so with agitation, so patient is agitated, should include the distraction strategy, distracting the patient, ask the client to take a walk. I'm not sure if you have dealt with agitated Alzheimer's cases. Very challenging and very difficult to take care of them. And you'll find that the distraction, most of the time, would work with them. Ask them, like, for instance, to take a walk, decrease the environmental stimuli, approach the client very calmly, calmly and very gently with an assurance, and not to demanding anything from the client is not a good thing. We have to, if they they eat they have 2 lunches and they will ask for another lunch, that's fine, because first, number 1 is they forget. Number 2, they most of the time they are pacing in the hallway in their room, and they are very active and they lose a lot of energy. Number 3 is that don't challenge them, don't argue with them, and you have to always be kind of in other words, that the strategy to be non-demanding anything from the client and to not argue with them. And then so the answer is number 4. Number 31.
The 3-day post-operative client is reporting unrelieved pain at the incision site 1 hour after administration of narcotic pain medication. Which action should the nurse implement first?
So this is a pain management. I have a few questions about pain management. So reporting unrelieved pain and the incision site 1 hour after the patient had received the narcotic medication.
Number 3.
Exactly. Thank you. Why one is incorrect?
Because they're experiencing a complication from the medication.
The nurse should assess the client first. I mean, that's
Right.
the bottom right? So, and this may be in a an appropriate intervention, but it's unrelieved pain 3 days after the surgery. It may indicate a problem. So we have to assess the patient first, right? So that's why number 1 is incorrect. Number 2, the client in pain is not ready to learn. They cannot learn when they are in pain. So if the narcotic medication is not successful, something else may be occurring. So patient may be experiencing other maybe complications. Something is cooking, as we say, right? So number 4, elevate at the head of patient's or client's bed. Repositioning the client may or may not help. So but we have to assess the client first. So I think the key element here is that, or keyword, or the answer should be around assess first. So assessment and then intervene. 32.
The client is reporting left shoulder pain. Which intervention should the nurse implement first?
So left shoulder pain implementation now. It's and sometimes implementation includes assessment, by the way. Don't be like, be confused. Sometimes, students get confused is that this is implementation. This is should be like intervention and should be a task or action. Like, have to give medication or do something, but it's an assessment. Could be an assessment. Not, sorry. It could be sometimes. So assessment is part of the implementation when it comes to actions. So assess the neurovascular status of the left hand. So the nurse should assess the client for potential complications to determine if the pain is expected or pain recurring. That's sometimes requires that we have to call the PCP. And if you look at 2, for example, 2, the nurse must check the MAR to determine when the last pain medication was administered, but it's not the first intervention here. Now, what about number 3? The nurse must rule out complications that require the medical intervention before medicating the client. And 4, when it said administer the client pain medication, which is an actual giving the patient, actually giving the patient or administering the drug to the patient, that the nurse should not administer any pain medication before ruling out. We have to rule out complications first. And
so
check
number 1?
Exactly. Yeah. So we have to rule out complications and check the MAR before we give the drug. So number 1 would be correct answer. 33. So 33, it's a nurse caring for client in acute pain as a result of surgery. Which intervention should the nurse implement? In this case, the answer should be administer pain medication as soon as the time frame allows. So, which is very classic, a traditional way of when we prescribe, or pain medication prescription given PRN, then it should be given. We have to assess or check the time frame and find out when the last time was given. So pain medication should be administered at the frequency ordered by if it's acute 3 hours, then should 3 hour lapse, and then we can, if the patient asks for the drug, then we can give it. Otherwise, we should be finding out other ways of management. Maybe another NSAID can be given, not the narcotic drug, or if the frequency is insufficient or ineffective, then we can just adjust the kind of the dosage or time frame. So that should be in consultation with the prescriber. But pain management or pain medication should be administered at the frequency as being determined and ordered by the provider, and not just when the client requests the drug or asks for it, especially for acute pain. So we have to stick with the frequency and time frame, Q 3 hours, Q 4 hours, Q 6 hours. And then if we find that the time frame or the dosage, maybe the time frame is ineffective, then we may sometimes, instead of 6 hours, we can make it in consultation with the provider, can be within restrict to be 4 hours instead of 6 hours. Sometimes we increase the dosage. So at least it has to be in consultation with the provider. The number 2, it said use non-pharmacological methods. It should never replace medications, because they should be used in combination to help and assist the patient become comfortable. So the comfort level is not going to be a resultant or result just from the non-pharmacological. So non-pharmacological methods, it should be implemented in conjunction with or associated with the medication. And then if you look at number 3, the cold or cryotherapy is usually it's an immediately used right post-op, like after the injury, after the post-op, or after post-injury, immediately. And the heat application is usually a later time, like immediately after the injury, after post-op, like right after it, either it's the post-op or injury, then we can use the cold applications. But heat applications, usually it's done or applied at later time. And it said number 4 is that to instruct family members to administer medications with the PCA, it's the only one who can do it or activated is who?
The patient.
Yeah, exactly. 34.
I'll read. Which nursing intervention is the highest priority when administering pain medication to a client experiencing acute pain? Check for the client's allergies.
Before that, it's correct, yes. So before giving any medication, we should assess for any allergies, but this is not priority intervention.
Is
Let's
it
say the highest.
verify the time of the last dose?
I think it's vital sign.
Discuss the pain.
Okay.
Everybody said a different
Okay.
answer.
I think it's vital sign.
I think it's verify the time.
I think it's vital sign.
I think it's check the client's allergies.
Before you do anything with the patient, will be it's very simple, and it's it should be done.
Pain?
Yeah, before you do anything, vital signs or
You ask the
for
patient for
allergies
the
or anything,
pain.
you discuss with the patient first, right? So you would discuss it. So the nurse should question the client because we are going to rule out complications and determine which medication before you do anything else, because we are going to discuss with the patient and to rule out any complications and to determine which medication and amount would be most appropriate for that patient. So this intervention it's an assessment also. It's an intervention, but it's an assessment at the same time. So if you look at number 1 for vital signs, I mean, it's important to monitor the vital signs, but it's not priority intervention before administering the medication. And number 2, we should verify the time the last dose was administered to determine the time, the extent. I mean, the next dose could be administered, but again, this is not priority. So same thing with the with check for allergies. again, sometimes, all of them looks like, all of them are correct. But the bottom line here is that before you go do anything else, you have to discuss with the patient, and then you move on to verify the last time was given, and then probably gonna ask for allergies, and then the last one is to do vital signs.
So you discuss the pain with the client before you check the client's allergies?
You see, I mean, the question didn't even specify if this is the first time being given. It said here, highest priority when administered pain medication to client experiencing acute pain. Could be this patient on this medication, so yeah, we have to discuss it. Yeah, before you do anything else, because
Okay.
that's a form of assessment also. It's a form of assessment. So 35.
Which intervention is appropriate for the RN to delegate to the UAP when caring for the client experiencing acute pain?
And within the scope, I think we, talk about this earlier about the scope of practice, about LPN and the assessed personnel.
Is it number 2?
Exactly, number 2. 36. The nurse is administering a opioid narcotic to the client. Which interventions should the nurse implement for client safety? So we would go with, for this question, with 1, 3, and 4. So the 1, this procedure, when you compare the hospital number on the MER with a bracelet, which is, again, it's we do this all the time. So this procedure ensures the client safety, right? Preventing the medication from being given to the wrong patient or client. Number 2, have the witness verify the wasted portion of the narcotic. It's not safety issue. It's correct, by the way, but it's nothing to do with safety. To do what? Well, how would you label this if it's not safety element or safety issue? It's a legal requirement. So it's not about client safety. It's correct. Number 2 is correct, but it has to do with the legal requirement, not patient safety. And number 3, to assess clients' vital signs before administering the drug. Yes, that intervention would prevent giving narcotic to an unstable, compromised client. And number 4, determine if the client has an allergy. We talk about this area. Determining the allergies would address patients' also safety as well. We can prevent allergic reactions when we assess for allergies. Number 5, clarify all pain medication orders with the healthcare provider. Is that correct? I mean, is that realistic? We don't do that all the time. No, it should not be realistic to recheck all orders with the patient.
So Professor, number
Yes,
two is correct, but in this case, it's not an answer. Because
it's absolutely correct, but it's not legal. It's a
Legal.
legal implication, nothing to do with patient safety.
Right, okay.
37, which nursing intervention is priority for client experiencing acute pain? And this one is basically going to be around the assessment. Same thing, we assess verbal and nonverbal cues because pain is subjective. And wait for the client to request pain medication. Some patients, they are hesitant to ask, and you learn about this from other courses, that cultural implications or cultural, like like assimilation of cultures, and cultural reasons and factors may play, like a factor here that preclude them and may make them hesitant to ask for pain medication. So some patients are hesitant to ask for pain medications and believe it is a sign of weakness, or to ask for pain meds. So that's from the cultural perspective. So number 3, administer pain medication on a scheduled basis. There are times when pain medications or prescriptions are given on a routine basis. So, and not the best answer, because assessment takes priority at this point. And number 4 is to teach the patient or client to use only a measure every hour for the pain. Now, the alternative therapy, like imagery or placebo or other, like other non-pharmacological interventions, they are used in a combination. Again, I think I mentioned about this one earlier, is that they can be used, but in combination with meds, but they will never replace medications. So in conjunction with, in association with, non-pharmacological implications or applications can be implemented and administered with medications, but they do not would or should not, they should never replace medications. 38, nurses conducting an interview with a 75-year-old client admitted with acute pain, and which question would have priority when assisting with pain management. So as you assess pain, in pain management or with pain management, what will be the first thing in terms of prioritization of tasks? What will be the question
1.
that will take priority? That should be 1, yes.
Yeah.
So the answer would be to indicate if the client has a negative experience that may influence the client's pain management. And what about previous surgeries? Previous surgeries would be pertinent information, but not for pain management. Number 3, have you had or have you ever been addicted to? So before asking this question, we should have specific information to make assumptions and to suspect the drug abuse or use. And then the last one, do you have a list of your prescription medications? Discussing patients' prescription medications is necessary. It's important, necessary, but asking for a list of meds will not address the client's pain management. So it's kind of irrelevant at this point to talk about medications or prescription meds while we are looking at the number 1 strategy to alleviate patients' pain. So I believe that we reached the conclusion here, the last slide, and which concludes our session.